Hello everyone, my name is Dr. Muaaz Masood and I'm a resident physician in internal medicine at the Medical College of Georgia at Augusta University. The collaborator on this project is Dr. Lisa Dyke, who's a cardiology fellow at the same institution. We present an interesting case of an African American male with respiratory and glomerular involvement who was found to have ANCA-associated vasculitis, or AAV, and how recent data from the Paxivus trial shaped our management of this patient. AAV represent a rare conglomerate of similar diseases characterized by inflammation and destruction of small vessels. AAV comprises of three main diseases: granulomatosis with polyangiitis, or GPA, microscopic polyangiitis, MPA, or eosinophilic granulomatosis with polyangiitis, or EGPA. The annual reported incidence of AAV in the US is 3.3 per 100,000, with a very high mortality if left untreated. Our case is a 58-year-old African American male with a history of congestive heart failure who presented with one-day history of dyspnea and hemoptysis. He denied fevers, chest pain, weight loss, dysuria, or recent travel, and his vital signs were within reference range. Laboratory studies were unremarkable with the exception of a creatinine of 4.87 on presentation. Urinalysis was notable for microscopic hematuria, and chest radiograph demonstrated bilateral patchy airspace opacities. The patient received empiric antibiotics and diuretics, and further studies revealed a positive myeloperoxidase anti-cytoplasmic antibody, a negative anti-glomerular basement membrane antibody, and negative proteinase 3 antibody. Given the concern for AAV, the patient received pulse doses of methylprednisolone for 3 days, followed by oral steroids. Renal biopsy is shown here in figures 1 through 4. Figure 1 shows global glomerular sclerosis with mixed interstitial inflammatory infiltrate and foci of moderate tubulitis. Figure 2 is a single intact glomerulus with a segmental fibrocellular crescent. Figure 3 is a silver stain with segmental fibrocellular crescent without vacuoles, spikes, or double contours. And Figure 4 is an immunofluorescent stain which is negative in the cortex or medulla. The patient's clinical condition and renal function significantly improved after steroid initiation, and the patient received induction therapy with rituximab followed by cyclophosphamide, which was planned for outpatient. He was discharged home with close follow-up in nephrology and rheumatology clinics. Testing for ANCA is recommended in any patient with suspected AAV. The diagnosis should be confirmed with skin or renal biopsy. However, biopsy should not delay treatment in cases with high suspicion for AAV. Typical findings on renal biopsy include focal, crescentic, sclerotic, or mixed lesions, and the mainstay of treatment is induction therapy with steroids in combination with either rituximab or cyclophosphamide. Recent data from the Paxivus trial published in the New England Journal of Medicine concluded that plasma exchange does not reduce the incidence of death or end-stage kidney disease, so we opted to defer plasma exchange in this patient. Following 3 to 6 months of induction, patients who achieve remission should be initiated on maintenance therapy with rituximab, and alternative agents may be used for maintenance therapy based on patient-specific factors. These agents can be azathioprine, methotrexate, or mycophenolate. The highlights of our case is that it is paramount that clinicians gain a deeper understanding of AAV to promptly recognize and treat this highly fatal disease. Biopsy should not delay treatment in cases with high suspicion of AAV, and recent data has shown that plasma exchange does not reduce the incidence of death or end-stage kidney disease. Thank you for listening.